There's not much in the peripheral blood, not much in the bone marrow, but we see spleen, we see pancreas, kidney, liver, a lot in the lung, because they're pretty big cells, human, if you put them into a mouse. So a lot of them by IV will get trapped in the lung. Skeletal muscle. Now, most of interest is they found it in the brain. So it suggests these cells cross the blood-brain barrier, and in cardiac tissue. And these results have been repeated by other groups. Subcutaneous administration, interestingly, is you've got a little bit more in the liver and less in the lung. So, and the distribution was the same. When they looked at looking at these cells, okay, we inject them in, where do they go? Are they attracted to areas of damage? Yes, they are. You'll see a majority of cells just zoom into areas of damage. So it's, once again, their physiological role. If I give them back by IV, are they just going to go and implant everywhere? Or will they home into these areas of damage? And that was some great work done by Wu et al. On looking at damaged heart. This is work where we've traced the stem cells, we've put him in by IV in a cerebellar atrophy patient. It's very interesting, I always show this because it's a clear example. He's got Deprutan syndrome in the right hand, so he's got 11 inflammatory tendinous nodules in his right hand. His left hand's completely free. We use 99-TC-HMPAO as a tracer on the cells. This was done with a professor in radionuclear medicine in Europe. And you can see where the IV, 24 hours later, we see where the IV has gone in. You see his liver comes up, there's some slight in the lung, a bit in the bone marrow. But what's most important, you'll get a background, you always get background in the bladder and in the large intestine with 99-TC, technetium. But most importantly is the cells have gone to his right hand, not in his left. His left had no inflammation, but his right hand. It was able a few days later to start reducing these nodules, and they started reducing and he got movement. But I use this as an example that we can trace the cells even by IV, and they will home in. There's another great paper that's come out by another group where they've injected adipose-derived stem cells labelled intra-articularly into the hip, and they've seen the cells labelled into an inflamed angle in the same leg. So it stayed there, and they found it in the inflamed angle as well. So they do home into areas of inflammation, and there's other research to suggest. Now, Osiris has done a lot of work, which is one of the first large companies to look at being able to put a stem cell in a vial and sell it like a drug in that sort of model. And what they were able to show is that these cells are very trophic. They produce a plethora of growth factors. One of the most important things is they're very, they have an amazing ability to have an anti-inflammatory effect. You'll get a very, very small immune response to these cells. And it's something they've seen in MS trials and some of the RA trials where they've seen there is an anti-inflammatory effect. And one of the major growth factors, which is probably not listed here, is interleukin-1 receptor antagonist. It's a peptide that's secreted mostly by monocytes. It's secreted by these particular mesenchyme stem cells, but it is the most potent anti-inflammatory our cells can make. So when we look at an injury response cascade, a 4-year-old won't form a scar. We have an acute injury, we have these growth factors come out, we then have mesenchyme stem cells go to the area, they secrete a whole lot of other growth factors, and then we have crosstalk, and we have, in a 4-year-old, this is much larger, that is much smaller. In a 90-year-old, this is much smaller, that is much larger. We get a bigger scar. So what's the fate of these cells after implantation? There's some results to suggest that when they disperse into adjacent tissue and become smooth muscle fibre, there's some good results, in particular when they looked at incontinence models, when they're injecting the cells into the bladder. However, very little of them. You see, it's not what we expected to see. Okay, well, there's 90% of them are turning into something, because you can label the cells and see which ones have actually turned into something in animal models. Is it the case that they differentiate into component cell type and integrate with the tissue? We well know that they secrete this plethora of growth factors and healing factors, and we well know they attract growth of blood vessels and facilitate tissue formation. So, conclusion derived from the literature so far, and if I make it from six months, not the latest 6 months, is that local accumulation, implantation, large number of these cells can improve the structure and function. That's really the conclusion we can derive. Is it because they change and they help, or is it because they differentiate and help, or is it because they go there and secrete something that further promotes the other cells in the area to heal? If we look at differences between amount of mesenchyme stem cells that can be turned into osteoprogenitor cells, which is a typical assay from bone marrow, from fat, I mean, this is just a typical, usually around the 10,000 times more cells. What was of interest to me is I wanted to find out, plastic surgeons in particularly know about a procedure called fat transfer, and a lot of you here probably know about it, or autologous fat transfer. We take fat and we use it as a filler, whether it's in the face, whether it's in the breast or in the butt, as some people use all around the world. But it's been around for a long time. It was first approved by the FDA in 1966. I mean, what are we really doing? We're getting rid of the lipid and taking the stromal vascular fraction. Are we doing anything different than a fat transfer? But I went through the very, very old literature, all dating all the way back to 1896. I wanted to find out, have they used fat for anything else outside of cosmetic purposes? And you'll see here, long-term results of successful fat grafts for tibial defects, 1913. Large unsuturable umbilical hernia repaired by large subperitoneal fat graft, 1913. Free fat and fascia transplantation in the treatment of ankylosed joints and diseases of the bone, Medical Journal of Australia, 1914. So it was, I mean, there's all the way down from treatment of war injuries of peripheral nerves to gangrenous and abscesses, pulmonary gangrene and abscesses, 1911. All these papers are prior to 1920. There's others between 20 and 1966, which most of Publine, Medline, you'll see it's 1966 onwards. It's made us a bit lazy because we don't go back to the libraries as we've done in the past and look down medical index, which used to take forever. But it's something that led to believe that fat in itself has some healing quality. If you take other tissue and implant it, it's going to necroticize. Why does fat sustain itself? Why is fat showing other results outside of just its benefit to fill? And why does it last for so long, if that's the case?